Good evening, ladies and gentlemen. Welcome to another edition of the Ultimate Pulmonary Wellness Lecture Series 2020, a partnership with Pulmonx. Our guest this evening is Dr. Gauhar. Dr. Gauhar is an assistant professor of medicine from the Division of Pulmonary Critical Care and Sleep Medicine from the University of Louisville in Louisville, Kentucky. Welcome to the show, Dr. Gauhar.
Thank you very much.
So tonight we are going to be talking about a breath of fresh air for patients and clinicians. Let's do it, my friend.
All right. Well, thank you very much, Noah, and thank you, Pulmonx, for arranging this wonderful webinar. I'm hoping that this will be very helpful and informative for our patients or potential patients. I'm very excited to talk about endobronchial valves for emphysema, a breath of fresh air for patients and clinicians. And I think this title will probably explains to you the value of this intervention and what it means to our patients and for the physicians. So let's talk about our program here at University of Louisville. BLVR is the abbreviation that I'll be using, or you'll see on slides. That's bronchoscopic lung volume program. So Dr. Hiram Rivas-Perez is the director of our program. And then there's me at the bottom. I'm the interventional pulmonologist. I do most, if not all, of the procedures. Dr. Rivas-Perez is very good in evaluating patients, screening them, and making sure that everything is done according to plan and according to standards of care. And then we have Chrissy.
We have your coordinator.
Yes,
we have Chrissy.
She is known nationwide as Chrissy. She's like Cher. She has only one name. And she is a worker bee and a queen bee all in one wholesome package. And we really appreciate her enthusiasm and her help and her support. And this program would not be possible at all without her. And so that's why her picture is bigger than our picture, because really it's her program. And so for all the effort and all the help and support and making this possible, she gets the tiara. And I realized when I was making this slide that this tiara is probably the most expensive thing that I've gotten, Chrissy, so far. So you're welcome, Chrissy. So let's talk about COPD, chronic obstructive pulmonary disease. A lot of our patients often get confused between these terms, COPD, emphysema, chronic bronchitis. But COPD is a group of chronic progressive lung conditions that are characterized by obstruction to airflow. I have highlighted the terms group and chronic and progressive, which means that COPD is not a disease. It's an umbrella term for a lot of lung conditions that are different in some ways, but similar in others. And they are also chronic, meaning they don't develop overnight or over a few weeks. It takes several years to develop. And they're also progressive, that if left untreated, they continue to affect lung function and also affect quality of life and eventually mortality as well. And the one thing that brings all of them together in this particular term is that they're characterized by obstruction to airflow, meaning when you want to breathe out or in, air doesn't go through the bronchial tubes as normally as it should. Most of the COPD that is seen in the world is because of cigarette smoking or tobacco use in one way or the other. It's a major cause of death and disease in the world. It's not an unusual or very rare disease. It's a major cause of death and disease in the world. Just to give you an idea, 16 million Americans suffer from COPD. So obviously a huge health problem. The typical symptoms of COPD, which many of our patients and listeners may actually know a lot more than some of us do, because for them this may be day-to-day life. But typical symptoms of COPD will include shortness of breath, and typically it's inability to take a deep breath in, but it could be otherwise. Cough, sometimes associated with sputum, and chest tightness. These are some of the common symptoms of COPD. This is what I call the downward spiral of COPD. As I had mentioned earlier, COPD is a progressive disease. It continues to eat away at your quality of life and also your life in general. So when when you develop COPD, you have shortness of breath, and we all know we need to breathe to live, and we need to breathe well to live well. So as your lung function decreases due to COPD, you start to slow down, cannot do most of your activities, which results in wasting away of your muscles and bones. It's a use it or lose it kind of a phenomenon. And as you lose your muscle and bone, it has a double hit on your health and on your body, that you're losing muscles, you're losing bone, that's making you weak, deconditioned, debilitated, and your lung function is decreasing. So your life is just spiraling down, and overall your quality of life, the things that you want to do, the things that you want to enjoy, or as one of our patients said, the things that define life start to just go away from your life. So it's clearly a very serious health condition. So let's go into the details of the different types of COPD. As I said in the beginning, COPD is a group of diseases. There are many different diseases under this umbrella. And for the sake of bronchoscopic lung volume reduction, we have to focus on emphysema, which is a type of COPD. The other common type of COPD is chronic bronchitis. And then there are many others, which for the sake of this discussion, we will not go into. But what I want my listeners to understand at this point is that just having COPD by itself does not mean that you can qualify or will benefit from the valves because these valves are specifically designed for the emphysema type of COPD. So what is emphysema? Well, emphysema is a type of COPD, and what happens in emphysema is that the lung tissue is gradually and progressively destroyed, which leads to trapping of air in the lungs. I like what one of our patients described once, and he said it's almost like you take a big breath in and you dive underwater, maybe in a swimming pool, and then you come up and just blow out a little bit of air, and then you have to take another breath in and go back in and just come up, and you get only a little time to blow air out. And over time, obviously, you feel like you have so much air in your chest and so little time to breathe out. And he said that's what living with COPD or emphysema feels like. Because of all the air that gets trapped in your lungs. So the lungs get ballooned up with extra air, which has an effect on everything that surrounds the lungs. As you can imagine, the chest is an incredibly important part of the body, has heart and big vessels, and the diaphragm, some of the most critical organs in the body are in the chest. So when the lungs become bigger than what they should be, it has an effect on everything around. On the other part of this slide, you see what I can only call our hall of shame. These are all the different ads that have been used in the past, going back decades, when smoking used to be considered something fashionable to do, something likable to do. It used to be thought of a harmless habit. Even doctors used to promote it. And it's just, whenever I look at this slide, I often remind myself that despite all the knowledge and all the research and all the technology, we still have to be very humble and always keep in mind that there are more things we don't know in medicine than things that we know. And now we are dealing with the damage done to the lungs and to health because of this habit. Well, emphysema, as I discussed, is a type of COPD. So this is just elaborating on it a little bit more. In the top part of this slide, you see healthy lung. So healthy lung is very elastic, which means that as we breathe in, it expands with air. And as we breathe out, it collapses and lets the air go out. In the top part, in that circle, you can see the microscopic representation of lung. It's almost like looking at a piece of sponge with little holes, and those little holes are your breathing parts where oxygen is absorbed in the blood and carbon dioxide is removed. So that's normal lung. And what happens with emphysema, as lung is destroyed, those holes become larger, as you can see in the lower part in that circle, and more air is trapped. So just imagine those circles, millions and billions of them all over the lung, and they're all trapped with air. So that causes air to get trapped, the lungs become bigger, and that pushes your diaphragms downwards. And the diaphragm is a large muscle that separates your chest cavity from your abdominal cavity, and it is the single most important muscle to help you breathe. And as it gets pushed down, it's always it's almost like doing a bench press every time you breathe, because it's having to push against that big expanded lung that's sitting right on top. And it's not going to function. It starts to tire out the diaphragm, and really the endobronchial valves are designed to reverse that process, get the lungs back to its normal shape or near normal shape, so the diaphragms can come up and the load over the diaphragm can be reduced.
Excuse me, Dr. Gauhar, if I could just ask quickly, you mentioned that this is for emphysema patients. What about for patients who have a combination of emphysema and chronic bronchitis? Are they still candidates?
That's a good question. And oftentimes it becomes a little difficult to decide which particular process is the dominant process. Now, there are certainly patients who have chronic bronchitis, but when we look at their imaging, meaning chest x-ray and CAT scan, when we look at their breathing test, it seems that the emphysema part is actually the main problem. And in those cases, the valves can certainly be considered. It all depends on what is the predominant process in the lung.
Thank you.
All right, so this is a typical chest x-ray of an emphysema patient. It has all the main features of emphysema. So on a chest x-ray and on a CAT scan, air will appear black. And normally, obviously, your lungs are filled with air, so it will appear black. But in emphysema, the top part, as you can see, it's a lot more black than what it should be, to the point that where you can't even see the ribs over there. That's all the extra air that's trapped. The other thing you can see is the widened rib spaces. The lungs have expanded to the point where they're stretching the ribs apart, and the ribs are C-shaped bones that help you breathe, and there are muscles attached in between that are important muscles of breathing. And so when the ribs are stretched like this, those muscles cannot work very well. The other thing that you can see is the flattened diaphragm. Again, the lungs have expanded to the point that they're pushing those diaphragms down. Normally, the diaphragms are dome-shaped structures. They should be curved up, and with each breath, they flatten, and that helps the lungs expand. But when the diaphragms are already flattened to that point, they can't really do much. So on this slide, you have the standard care of emphysema. And most of our patients know that most of their treatments for COPD or emphysema come in the form of inhalers. So most, if not all, patients with emphysema, particularly air trapping, will need inhalers. And those are your main treatment that you will continue for the rest of your life most of the time. The other very important part of emphysema treatment is pulmonary rehabilitation, which is an exercise program often provided as an outpatient therapy, which helps to improve your exercise endurance. Now, one important thing about pulmonary rehabilitation is that it does not change your oxygen levels, and it does not change your numbers on a pulmonary function test. What it's designed to do is help you do more with the kinds of lung problem that you have, but it's still very important because it improves patients' ability to function better, and so overall has a good effect on patients' well-being. But this is where we have been for a long time, and a lot of our patients, despite being compliant with medicines and despite going through pulmonary rehabilitation, do not feel that they are able to breathe well or live the kind of life that they would want. And so then we think about more invasive therapies, which are lung volume reduction surgery and lung transplant. Lung volume reduction surgery is a kind of surgery where the chest surgeon goes in and essentially cuts out part of the lung that is not functioning, part of the lung that is trapped with air. And so by cutting out that part of the lungs are reduced to something of a normal size, and that can improve the function of the diaphragm. The problem or the issue with this particular intervention is that it's obviously very invasive. It requires you to go through anesthesia, go through surgery, and many of our patients are already suffering from severe lung problems, severe debility, and so it increases the risk of complications and poor outcomes. And then you have lung transplantation, which essentially replaces the diseased lung with a new lung, which obviously is a much bigger intervention, a more invasive intervention for COPD. So for the most part, we have been somewhere stuck in the middle of this slide. Most of our patients were using inhalers, going through rehabilitation, doing exercise as much as they could. Many of them were either not interested in surgical treatments or were deemed too sick for surgical treatments. And so most of our patients and clinicians were somewhat frustrated and hopeless. And this is why I go back to the title of my talk, a breath of fresh air for patients and clinicians, because now we have something that we can put in the middle of the slide before we think about more invasive, more complicated, more risky procedures, something that we can offer to our patients to help them live the kind of life they want to live with an acceptable risk profiles, an acceptable safety profile. And this is where we will introduce our main topic, which is the Zephyr valve. So Zephyr endobronchial valves, you can see this picture and it obviously looks pretty big, but it's actually a pretty small device. Just think of it as it's about the size of the tip of this pen, maybe a little bigger, give or take. So it obviously has to fit through a bronchoscope and has to fit through your bronchial tube. So it's a fairly small device and it's a one-way valve. What it means is it can allow air to come out, but it does not allow air to go in. And so when we put it at the mouth of a lobe is a part of the lung. When we put at the mouth of the lobe, it gradually allows air to leak out of that lobe and exit, but it does not allow air to go in. So over time, that lobe deflates like a balloon and goes back to something of a normal size. And that's really the gist of how these valves are supposed to work. And I think we have a little video that may help our viewers and listeners see how they're implanted and what they look like when they're implanted. So this is that slide that I was referring to. Now we have something that we can put in the middle. And to me, as a clinician, as a pulmonologist who does these therapies, this slide tells me a lot because it's such a nice therapy that it takes some of the medical part from the left side of the slide. So it's somewhat minimally invasive, but also invasive on the right side, but it's not extreme in any way. So it's right in the middle, and perhaps it's the best of both worlds. And that's just me.
I agree 1,000%. To me, this is the most exciting thing to happen to COPD in my 30-year career.
Absolutely.
I feel like for years we had we had these, we had the inhalers, and then you'd have a second inhaler, then there'd be combo inhalers, different, and you'd see some changes. Yeah, absolutely. But the patients that have had this, it's really one of the few things that really gives them their lives back.
Yes.
It's exciting.
Absolutely. No question about it. So let's watch this video and let's see what we can learn about Zephyr valves.
The Zephyr endobronchial valve treatment for emphysema, when medical management alone isn't enough. The Zephyr endobronchial valve is a proven, minimally invasive treatment designed to improve breathing, activity, and quality of life for emphysema patients who are breathless despite maximum medical therapy. The Zephyr valve procedure is performed under general anesthesia or conscious sedation, where a standard bronchoscope and flexible delivery catheter are used to guide the valves into the target lobe and desired airway. Multiple valves are implanted to ensure complete occlusion of all airways leading to the target lobe of the lung. Valves may be placed at the lobar, segmental, or subsegmental levels, dependent on the airway anatomy. Trapped air in the treated lobe escapes through the Zephyr valves until the lung volume of the treated lobe is reduced. The valves can be removed and replaced if needed. After treatment, the remaining lobes can expand more fully, and pressure on the diaphragm is relieved, improving breathing mechanics and overall lung function. Patients who respond to Zephyr valve treatment often experience meaningful improvement within 45 days. Zephyr valve treatment is intended for patients with emphysema and hyperinflation of the lungs. Patients with low or no collateral airflow in the lungs have been shown to be the best candidates for the procedure. Pulmonx offers clinically validated patient selection tools that can accurately identify likely responders. These are used together with standard pulmonary tests and CT scans to determine whether a patient is a good candidate for Zephyr valves. The Zephyr valve is the first endoscopic emphysema treatment proven in multiple clinical trials to deliver clinically meaningful benefits across several important patient measures: quality of life, exercise capacity, dyspnea, and lung function. With thousands of patients treated worldwide over the last decade, Zephyr valves are intended to be a long-term solution to help emphysema patients breathe better, do more, and enjoy a better quality of life.
So this is one of our patients that we treated with the Zephyr endobronchial valves. And you can see how this will affect the size of the lung and the shape of the diaphragm. So this is the image of the patient before the procedure. As you can see, the lungs are very dark, very black. You can't see the ribs, so filled with air. They're trapped, long tubular heart, diaphragms are flattened. And she received valves in the right upper lobe. And so you see immediately after placing valves in the right upper lobe, you start to see that the right lung is starting to look smaller than the left lung. So it's starting to deflate. The top part of the right lung starts to look more gray as air starts to come out. This is day one. Again, increasing opacification of the right lung, the diaphragm starting to look more like a dome, the right lung starting to look smaller. And this process continues to day two and day three. And on day three, you can see the right upper lung is completely opacified. You can see the margin that separates the right lung from the lower lung, and see the diaphragm. This is more or less a normal shape of the diaphragm as opposed to the left side, which is still completely flattened. Notice the smaller size of the right lung compared to the left lung. Notice the shape of the diaphragm compared to the left. And so this progression of changes on X-rays explains what emphysema is, if you look on the left side, versus what the valves are designed to do. So they're designed to deflate the lung to the point where it becomes somewhat smaller, meaning closer to normal, helps the diaphragm regain its normal shape and hence its normal function, all the while improving breathing and overall quality of life.
Dr. Gauhar, is air trapping the same as residual volume?
Yes. So it depends on how we address it. You know, when we are looking at an X-ray, obviously we don't see residual volume. The residual volume is a number that we get on breathing tests, and that's a more objective measure of how much air is left in your lungs at the end of breathing. Now, obviously, even in normal people, as we breathe out, we don't breathe all the air that's in our lungs, because otherwise, every time we breathe out, our lungs will completely collapse and we'll have to fill them up again with every breath. And that's just not a physiologically good condition. So even if I blow out as hard and as completely as possible, there's always going to be some air left in my lungs. That's called residual volume. That's the amount of air that I can never get out of my lungs. And there's a reason for it. We want to keep our lungs somewhat open so they don't completely collapse. But what happens in emphysema with air trapping is that residual volume becomes much larger. And then just to give you an idea, that the normal higher level of residual volume on a breathing test is about 120%. And some of the patients who are sent our way for consideration for this therapy may have residual volumes in the 200s, 300s. I think the highest that I've seen was close to 500%, which is unbelievable. But that's what residual volume is. It's the measurement of that air trapping on the breathing test. Does that answer your question, Noah?
Absolutely.
All right, let's move forward. All right, so this is some of the studies that have been done looking at Zephyr valves. So obviously there's a lot of research that goes into these kinds of interventions before they are brought out into clinical practice. And as far as the 6-minute walk distance was concerned, it improved from about 28 meters to almost 80 meters, when the minimum clinically significant is about 26. And St. George's questionnaire also improved. So minimal clinically significant improvement was dropping 4 points. And as you can see, in all these trials, patients treated with the valves compared to those who did not get the valves actually had an improvement in their dyspnea scores. So this is really what we are planning to achieve or wanting to achieve after we place these valves. We want to decrease air trapping, and so the total lung volume is reduced. There's reduced gas trapping, air trapping, residual volumes improve, which improves lung function, reduces your breathlessness, which helps you do more activities, and overall improves your health status. So once you get this, or once you refer to procedure for bronchoscopic lung volume reduction, what to expect? These valves are placed bronchoscopically, so you will be put under general anesthesia. The procedure lasts anywhere from 30 to 60 minutes, depending on how many valves are placed. You will stay in the hospital for at least 3 nights. And the most important reason for keeping you in the hospital is to monitor for a particular complication called pneumothorax, which we will talk about. And during this hospitalization, you will continue your usual COPD treatment, and you will be getting frequent chest x-rays. But other than that, there are no special restrictions. You will not be tied to the bed. You can walk around. There's no special dietary restriction. You will not have to stay hungry for several hours. It's basically to keep you in the hospital and monitor you and get x-rays on you. Once everything is stable, you will be discharged, and your doctors will continue to follow you at specific intervals depending on the particular program. We talked about pneumothorax. So pneumothorax is a complication of not just the valves. It's a common clinical condition of many different procedures, but also a complication of many different lung diseases. What happens in pneumothorax is that air gets trapped between the lungs and the rib cage. And as it builds, it compresses the lung. And if it builds enough, it can affect your heart and your circulation. And we think pneumothorax happens because as your lung deflates, or the part of the lung deflates where the valves are, the body is going to try to fill that space with something else. The body does not like empty spaces. And what happens is that you have compensatory hyperinflation or hyperexpansion, meaning that the part of the lung that's next to the deflating part expands to fill that space. And sometimes during that expansion, because that lung also has emphysema, it can, a small part of it can rupture and start leaking air, which can accumulate between the rib cage and the lung. And that is a condition called pneumothorax. And if our listeners and our viewers want to know one thing as far as potential complications, that's the one thing that I would want them to remember. This is perhaps the only reason we keep people in the hospital, to monitor for this particular complication. Other things that you can expect, which are usually not a big problem, but somewhat expected, is you may have a slight increase in your cough, in your sputum. You may even cough a small amounts of blood for a day or so. None of it is usually a big problem. You will continue your inhalers and your breathing treatments. Your COPD may transiently flare up, which means that you may have a little bit more symptoms, and sometimes you may require antibiotics and steroids. We have to understand that it's a lot for the lungs to handle these valves initially. These are foreign bodies, and so all of a sudden your lungs are having to deal with a lot of valves in there. So occasionally you may have increased symptoms, but these are usually not long-term problems. The most important thing we worry about or monitor for is pneumothorax.
Can I ask you a question? After the patient is discharged home and recovered, are they still at increased risk for pneumothorax, or is that just right after the procedure?
Good question. So in the studies, it was found that the risk of pneumothorax is highest, in the first 2 to 3 days after the procedure. And so that's why we keep people in the hospital for 3 days. Now, obviously, these complications can happen days later, but the risk is much, much lower. So beyond 5 days, the risk of this pneumothorax is much lower. The highest risk is in the first 2 to 3 days.
And how would somebody know, like, what are the signs and symptoms of a pneumo?
Shortness of breath and chest pain are usually the most important signs. And most of our patients who have pneumothorax, not just after the valve, but also after other clinical conditions, usually present with those symptoms.
I see. And what's the treatment, or is it just left to resolve?
Again, it depends on how severe it is, how large it is on chest X-ray, and what symptoms is it causing, how severe the symptoms are. If it's large enough to affect your breathing, cause severe chest pain, drop your oxygen, then most patients are going to need a chest tube, which is a plastic tube that is can be placed at the bedside under local anesthesia. It goes between your ribs and sits in that space between the rib cage and the lungs and lets all that extra air come out. And as your lung heals, that tube can be removed. All right, let's move on. And now some of the things that I want to bring to attention just to resolve any misunderstanding is that bronchoscopic lung volume reduction is an adjunct to therapy, meaning it does not cure COPD. You will still need all your medicines. You will still need your pulmonary rehabilitation. So everything that you've done for your COPD, you will continue to need it, because treating a part of the lung does not mean that the rest of the lungs do not have COPD or emphysema. So our patients have to make sure that they remain compliant with their medical therapy. They remain compliant with their immunizations, such as yearly influenza vaccine. You may still need supplemental oxygen. We've had some patients who actually were able to either come off oxygen or come down to lower levels of oxygen, but that's not always the rule. You may still need a supplemental oxygen. And yes, you cannot start smoking again. Don't think that this has cured your COPD or given your license to smoke again. So no smoking. So at our place, when we see patients or we consider patients for this particular treatment, there are a few things that we have to look for right up front. And this is what I would consider the minimum criteria for evaluation for bronchoscopic lung volume reduction. If you do not have this, then it's not that we don't want to do this for you, it's that it will not work for you. So we don't want to put you through a treatment an intervention that is not going to work for you. So you need to have an established diagnosis of emphysema, that particular type of COPD where this treatment has the potential to work. The residual volume that we discussed, which is a measurement of the trapped air in your lung, has to be 150% or above. As I mentioned, 120% is considered normal. And so it has to be at about 150% and above. And your symptoms have to be persistent or progressive, despite the fact that you're on appropriate inhaler treatment and perhaps have gone through pulmonary rehabilitation, but they're still progressing. So that's the minimum criteria that we will consider for this particular treatment.
When you're saying 150%, are you saying that the residual volume is 150% or the total lung volume is 150%?
It's the residual volume, which is the amount of air left in the lung at the end of normal breathing. So obviously you have to be willing to go through pulmonary rehabilitation. If you remember our previous slide, pulmonary rehabilitation is part and parcel of COPD management. So we strongly encourage patients to go through pulmonary rehab before the treatment, but sometimes they can continue part of it after valve placement. And you obviously have to be willing to go through anesthesia and bronchoscopy. You have to be willing to come to our clinics for follow-ups, and you cannot be a current smoker. So you have to quit smoking. You have to be quit for about 6 months, or at least willing to quit, because it doesn't make sense for us to put you through this treatment when you're still smoking and still your lungs are being exposed to cigarette smoke. The valves are made of a certain material, and if you have allergies to any of those materials, then obviously you can have adverse effects. That material can include nickel, titanium, nitinol, and silicone. And during our initial visits, we do check patients, at least ask them questions to help us understand if they have any sort of allergies to these materials. So when I see these patients in my clinic, this is what's going on in my mind. I'm thinking in two different paradigms. Number one is your safety. We want to do what is safe for you. We don't want to put your life and your health at any risk. So the first thing I'm going to think about is it safe for you to go through this procedure? And the second part is it going to be beneficial for you? Is it going to benefit you in the long term, improve your symptoms? So when it comes to assessing safety, we have to look at how severe your lung disease is, how low your oxygen is, how high your carbon dioxide is, which are all functions of the lung. Obesity, if you're obese with a body mass index of about 35, that can increase the risk of complications down the road. If you're unable to move much, if your mobility is very poor, then you may not be able to move much after the procedure, and that increases the risk of infections and other complications. Severe uncontrolled heart disease can increase the risk of complications, but this is something that can be controlled, can be assessed after treatment. If you have severe pulmonary hypertension, which is high pressures in the blood vessels in the lungs, can also increase the risk of putting you through anesthesia and putting you through the procedure. If you have something on your CAT scan that looks like it requires further evaluation, could be infection, could be cancer, could be an inflammation, that's something that takes priority. We first need to understand what's going on in your lungs before we put you through this valve treatment. So these are some of the things that we look for. And if you have any one of those, then most likely we will consider that the valves are not the safe intervention for you, at least at that point. Now, some of these things can be reassessed. And then, as we discussed earlier, sometimes you have coexisting lung diseases or lung diseases that will not benefit from valves. For example, you can have a large bulla, which is a large part of the lung that's essentially destroyed with emphysema and filled with air. And so these kinds of this kind of emphysema is not going to benefit from valves and may also increase the risk of pneumothorax and poor outcomes. So we will not consider this for valve treatment. We have pulmonary fibrosis, which is severe scarring of the lungs seen in smokers. This is another condition where the lungs become very stiff. It's a completely separate condition from emphysema and will not benefit from valves. If you have what's called paraseptal emphysema, a particular kind of emphysema, which is, as you can see, more towards the outside of the chest, this is another condition where valves will not be considered very safe. If you have something that looks like a nodule or mass, that could be a cancer or could be infection. This is another situation where valves will have to wait until we have made sure that this is not something that requires further intervention.
What about previous treatments for cancer? So like a lobectomy, does that preclude you?
Good question. So we generally wait about 3 to 5 years after treatment. So if you've had a lobectomy per se, that by itself does not exclude patients from getting valves. Now we do have to make sure that there's no evidence of the cancer coming back, because patients who've had lung cancer, for example, in the past, they are at high risk of having newer cancers. So we have to just make sure that we're not dealing with anything that looks like a recurrent cancer or a new cancer. But lobectomy by itself is not something that excludes you from getting valves. And then
and does the lobe matter? Does it matter which lobe? Because it seems like you do mostly uppers, or is that right, or do they vary?
Well, they vary. So we will look at a report called Chartis report, which is a report that is generated from your CAT scan, and that can tell us which particular lobe is going to be the best target. So it's not always the upper lobe, and it's not always the lower lobes. All right, now oftentimes a CAT scan will pick up other problems in other parts of your body, such as the liver, the kidney, the adrenals, the spine, heart, main blood vessels. And so if there's anything that we feel requires urgent attention, then probably the valves will have to wait. And as you can see over here, this is a CAT scan of aortic dissection, which can be a serious problem. So this is something that will require attention before we can consider valves. Now, so that was somewhat about the safety of the procedure. As far as the benefit, who will benefit from the valve treatment. So it has to depend how severe your air trapping is, because air trapping has to be a certain severity before we can address it. If it's very minimal, then valves are not really going to make much of an improvement. It also depends on whether the emphysema is affecting the entire lung or a particular part of the lung. So homogeneous emphysema is something that affects, the entire part of the lung or most of the lung, where a heterogeneous emphysema is something that affects, different parts of the lung, and usually we see it more towards the top part of the lungs. Functional status is important. Now we need to understand that these lungs are not designed to make you young. They're designed to help you improve your symptom. And so our patients and candidates for these valves need to have realistic expectations. You will still be living with COPD, but these valves are designed to help you improve your function. And obviously you have to comply with medical therapy and medical advice. And so after assessing safety and benefit, if we feel that the benefits of this intervention are more than the harm, then we proceed further. If the harms are more than the benefits, then we have to stop, we have to reconsider, reassess, maybe perform further testing, maybe wait for some of the problems to be evaluated, some of the comorbidities to be addressed before we can reconsider them. So this is somewhat of a workflow, and I would like to invite Chrissy at this point. So this just gives you an idea of how much Chrissy is involved in this program.
Well, once we get the referral, and typically a lot of our referrals are self-referrals, but we also get referrals from other physicians outside our community. So we actually just need to have the PFT, the 6-minute walk test, and we like to have an echo cardiogram, and we also will get a CT scan, because that is more than anything, we need that for the Chartis report, so that we can determine which is going to be your target lobe specifically for you as the patient. Now, also an ABG is important, just because the COPDers are sometimes CO retainers, so CO2 retainers, so we want to make sure that the carbon dioxide levels aren't too high. So once I have those tests, I could typically start to screen the patient. Occasionally we'll have to have a test repeated here at our facility just to be sure that it's done correctly. But then once that happens and it looks like the patient may meet that criteria, we bring them in and do a seminar just with the patient and their families. Here recently we've had to do COVID friendly and only do a few patients at a time with 6-foot distance, but we bring you and your family in and go over videos. We talk about the collateral ventilation and the Chartis assessment, which all these things are so important because for you to go to the website or the YouTube or the Facebook pages, it truly doesn't bring home all the important components of this procedure until you actually see it. So that has been very helpful for us and our patients since the trial started, and now that we have FDA approval that we're obviously doing it more on the commercial side. So we're bringing the patients in and going through the seminar. That way it makes their visit a lot easier once they finally do meet with Dr. Rivas or Dr. Gauhar. They are able to ask the questions that they need to ask because they've already learned so much at the seminar. So that's how our site has kind of driven our program, is to get the patient well informed and for them to know as much as they can to make an informed decision based on all the data we've collected from them and their testing, and for our doctors to help them with that decision, whether or not the risk weighs out the benefits and vice versa. The big thing I want patients to remember is obviously you still have COPD. Patients think this is a quick fix and they think, oh, I'm going to come off my inhalers and oh, I might come off my oxygen. Well, you're not going to come off your inhalers. You have 5 lobes that are all destructive from smoking. So obviously you still have 4 lobes with emphysema, so you will still sometimes experience exacerbations, and will obviously still need inhalers, your mini-nebs, and some patients, even if they didn't require oxygen before, might require it afterwards just because the whole physiology of the chest is changing as that lobe deflates and the other lobe reinflates into that space. So some patients may require a little more oxygen afterwards. Some patients come off it immediately. Every patient is different. But the thing that is most important is rehab. We cannot stress that enough. And the patients that in the trial obviously couldn't be in the trial unless they did the required visits. But for the patients now that are getting the valves, it's not a quick fix. It's something that you have to work at, and it's something that you have to be determined that you want this enough that you're willing to do the rehab part, because that, even without the valves, is so important, and the patients really need to understand that.
Chrissy, are you guys accepting patients who are doing tele-rehab, or does it have to be in-person rehab at this time?
Well, obviously COVID's thrown a monkey wrench into everyone's world. So a lot of the rehab facilities are opening now and doing a COVID-friendly type of thing, but I've actually, Noah, recommended your site and YouTube videos to patients to do a program at home. We obviously encourage them maybe to get a treadmill or an elliptical. I ask my patients to do a journal, just to keep a diary of what they're doing every day, to work on their upper body strength, because, with these patients, quality of life is everything. And when you can't even wash your own hair because all your accessory muscles are used just to breathe, that even washing your own hair is a chore. So that is one thing that we are accepting at this point, but we also have to go over things with the patient to make sure they're truly determined and that they truly want this and that their expectations are realistic too. Obviously we would like to see you get back to doing a lot more things that you did before COPD, but you also have to be realistic in the fact that, it's quality of life things, the things like walking to your mailbox and walking to the bathroom or dressing yourself or even drying off after the shower. playing with your grandchildren, you know, just the small things in life that make you happy. So expectations are a big part of it, and again, I can't stress rehab enough.
And Chrissy, I know with some of the other procedures like lung transplant, like there are strict requirements, like as far as family support. Are you able to go through the valve procedures, like if you live alone, or do you have to bring a family member with you for evaluation?
Typically, most patients have that support. We haven't really run across that too often. We've had some patients maybe that were single or divorced or widowed that had a friend if they didn't have a child or someone that could join them. But obviously, the support should be there, but we try to be support and rally around our patients and be their cheerleaders and try to support for them. But as far as the difference between transplant, you know, psychologically, there's a lot to it. There's a lot of anxiety and depression that goes with having this disease, and then obviously going through the treatment. But we feel like as far as support goes, it's important, but most of all is that the patient's determined and willing to do it on their own and to push themselves.
Gotcha. Thank you.
Thank you,
You're
Chrissy.
welcome.
All right, so this is what we call the Chartis report, and this is a very important test or an important result that we have to look at before we proceed. I will try to make this, for us to treat a lobe, it needs to have, you know, 4 different features. One is completeness of fissure. A fissure is the wall that separates different parts of the lung, and the more complete it is, the less the chance of it leaking between the lobes. So it has to have a high destruction score, meaning emphysema has to be significant in that part of the lung. And the score that we look for is at least more than 50. It needs to have a high inspiration volume, which is basically a measurement or a representation of air trapping, and low perfusion, that the blood flow to that part of the lung has to be low. So the closer the lobe is to this criteria, the better. And the Chartis report gives us these parameters where this is the completeness of the fissure, this is the destruction score, and the inspiratory volume. So we generally look at this report, which is generated from your CAT scan through a software, and decide which lobe or lobes can be evaluated during the procedure for valve placement.
Does every hospital have access to that?
I think, Chrissy, you can probably answer this question. This is something that's generated through the software. And I will have Chrissy answer this question because she's the one who contacts and gets us this report. So Chrissy, what's our process here?
Well, we need a high-resolution CT without contrast of the chest, lungs, and we would like to have that, if possible, in a navigational protocol. There is a protocol that we need, that the slices need to be sliced so thin there can be no gaps, because once we de-identify that disc and add it into the software to send off to Pulmonx for that report, it has to meet those specifications. Typically, a lot of the hospitals in the outlying areas or in other states, if we can get a hold of them ahead of time before they could do the CT, they can put in that protocol and determine how thin the slices are, and then just mail us a copy, or sometimes it could be loaded into an iCloud and we could pull those images and load them that way. But typically with the patients that are from some of the rural counties, we will bring them here to Louisville and just go ahead and do the CT here. That way we know it's done correctly.
Thank you.
Thank you, Chrissy.
You're welcome.
This slide will explain what collateral ventilation is, because this is a word that our patients, whether they're in clinic or before procedure or even after procedure, will get to hear. So this essentially represents how isolated that lobe is from the adjacent lobe. And the more isolated it is, the more walled off it is, the better when we're considering valve placement. So on this slide, this is representing the left lung, the top part, which is the left upper lobe, the bottom, which is the left lower lobe, and the wall between the two is called the fissure. So if there is incompleteness of the fissure, meaning the two lobes are communicating, even if I was to put a valve at the entry of the left upper lobe or the entry of the left lower lobe, it will still take in air from the adjacent lobe and continue to fill up. So the valve will not work. This is a condition called collateral ventilation positive. And if this fissure is complete and does not give any communication between the two lobes so that each lobe just stays separate, that's the kind of situation we want. This is a collateral ventilation negative, which means if I was to put a valve at the entry of the left upper lobe, I have the chance to deflate the complete lobe, and the same is the case for left lower lobe. So being negative in this particular way is actually good. Being positive is bad, which means you will not get valves. And this is something we assess during the procedure before we place the valves using this instrument called Chartis. It has a monitor that's attached to a balloon catheter. We pass this balloon catheter through the bronchoscope and place it in the target lobe where we are thinking about performing the valve procedure. And then we look at the monitor. So ideally, the airflow will continue to decline and go down to zero. This is a collateral ventilation negative situation, meaning we have been able to completely empty that lobe. So in a way, simulate what a valve will do if it were to be placed. So that's the kind of reading we want before we can place the valve. But if we get a flat line, meaning a plateau, it means that even though we have occluded the entry of the entry to the lobe, this lobe is still filling up. And so it's not declining all the way down to zero. It's still filling up with air, which means that it's filling up from behind this balloon. And so this is a collateral ventilation positive situation, in which case the valves will not work.
Dr. Gauhar and Chrissy, I don't want to cramp your style. We have about 10 minutes, not rushing you. Okay, I have till midnight, so feel free. But at some point, we're going to go to the speed round and go to questions from the audience. And we do want to bring Richard in. You're the ringmaster. Tell us when we do what.
Okay, well, let me go through this slide. It will take about a minute or two. There's a lot of data here, but I just want to give our patients some idea about what to expect after the valve. This is data from 2018. So the higher the graphs, the higher the bars, the better. These yellow bars are the treated patients, and the greens are the standard of care. And this is looking at different parameters, the FEV1, the residual volume, St. George's questionnaire, how far you can walk, and the total lung volume. So as you can see, all across the board, patients who got the valves did much better than patients who were treated with just standard of care. And about 84% of the patients were able to show improvement in total lung volume. And this is a busy slide, but again, it reflects that the three main areas of improvement that our patients can experience is improvement in dyspnea, which is your shortness of breath, in your activity level, and the whole psychosocial aspect of your life. When you can breathe better, you can do more. When you can do more, you can live your life better. And this is just a scientific way of not only documenting it, but showing it. And this is what our patients can expect after the valves. This is another way to show how symptoms will go after the treatment. So this line here is standard of care, meaning without the valves. This is emphysema symptoms. So as you can see, the emphysema symptom intensity continues to increase without the valves, and those patients who receive the valves are much lower. So the severity of symptoms was improved after the valves. So I will summarize that the bronchoscopic lung volume reduction with endobronchial valves is a new minimally invasive, low risk adjunct treatment that goes along with your standard COPD treatment. It is designed to reduce air trapping, which improves your shortness of breath and improves your quality of life. It does not cure COPD. And what's important on our part is to select the appropriate patients and work with the patients and their referring physicians so we can have our desired results. And I think this is where we will end. Thank you.
Awesome. Thank you. If we could bring Richard in, ladies and gentlemen, we have one of Dr. Gauhar's patients named Richard Zalecki. And Rich, are you here?
Yes, I am.
Welcome, Richard. Great to hear from you. So when did you have your valves done?
A little bit, I think a little bit over a year ago.
A little over a year, but could you tell us a little bit about what your life was like before the valves were placed?
Oh, it was terrible. I couldn't even carry a gallon of milk up a flight of 3 stairs. And there was, at nighttime, I would lay in my bed and just pray to God that He take me, because I was gasping for air, and I was even on oxygen, and I had no life. You know, my wife had to do everything for me. My grandbabies, I couldn't hold them. I couldn't take them for walks, do anything. And then
that's a tough one. Who referred you? Who suggested this procedure for you?
a doctor over at another hospital had told me that he heard of Dr. Gauhar doing a technique over here with valves. Said he was one of the best there was, and he sent me over to U of L, and I met with Chrissy, and we went through the procedures of, you know, the walks, the whole thing and everything, and then I met Dr. Gauhar, and he said I was a candidate for it. He said he believed that he'd be able to get around, and since then, I tell you what, I've gone fishing with my grandbabies. I take them for walks. I actually have life now. You know, it's like going from dead to being alive.
You got a second lease.
Exactly. And I mean, I smoked for 42 years, and I quit in 2015. And Dr. Gauhar told me, you know, hey, you know, you did it yourself, but we can try to fix it. And he sure enough did. I mean, from beginning to the end of the surgery, as soon as I went into the room, he told me, we're going to do this, we're going to do this, and we're going to do this. And hopefully when you come out, everything will be okay. That same day, I was up walking around the nurses' stations and walking down the hall without oxygen.
Amazing.
I mean,
And if you had to give one piece of, I'm sorry, go ahead, Chrissy.
Well, I was going to say, Richard, your valves were on October 22nd, and Dr. Gauhar implanted 5 valves in your left upper lobe. So October 22nd probably seems like it's been almost a year, just because you had this new lease on life, but it's not really been even that long.
Okay.
You're like living dog years now with these new valves, so you're getting a lot of bang for your buck.
Exactly.
Richard, if you had to say one piece of advice to patients thinking about this, what would you tell them?
I'd say go for it. It's a new life. It's like,
Awesome.
if you do what they tell you to do, and I've done everything the doctors told me. I haven't touched a cigarette. You know, I did the therapy, did everything that he told me I needed to do to get to where I was. And I believe if you do exactly what he tells you, you can walk out perfect. I mean, I'm a perfect example. I took my grandbabies fishing 2 weeks ago. I was working for 8 months, you know, and I don't even use oxygen anymore.
So Noah,
Awesome.
I can tell you a
Yep.
little story about Mr. Zalecki that really touched me. I saw him, I think in December, soon after Thanksgiving, and he had tears in his eyes, and he told me that he likes to cook. And after many years, he was able to cook the entire Thanksgiving dinner for his entire family, and that made his life. And,
Oh,
and
yeah.
it
That's amazing.
really touched me, and I could see what it meant to him.
Oh yeah, it did.
Amazing.
Because, you know, I had all my grandbabies and that, and you know, I used to, like you said, I used to cook Thanksgiving dinner and, you know, make the whole ball of wax and everything. And then finally being able to lean over and, you know, put a turkey in the oven and cook it and do all the other stuff, it was like, you know, a miracle for me.
That's amazing. Were you joking before when you said you had 10 grandchildren?
No, I wasn't. I do
You
have
have 10 grandchildren. Were you joking when you said you were 49 years old?
No, I am.
All right. So we're the same age. I don't know what I would do if I had 10 grandchildren. Final question for Richard, and then we're going to go to the speed round. Did you catch any fish?
Actually, my grandbabies caught the fish. The
Okay, awesome.
littlest one caught the biggest one, and she was so happy. And I'll tell you what, I had tears in my eyes because I promised them years that I would take them fishing. And I finally got to be able to do it. And that was,
Well,
it was like a miracle just to watch her eyes light up.
well, I'm not a religious man, but I say thank God didn't take you. He knew you were going fishing and Turkey. All right, Richard, thank you so much for sharing your story. It is time for the speed round between Dr. Gauhar and Chrissy. So we don't do it. You don't have to press any buttons. Whoever wants to answer first, just throw it out there.
Oh my God.
Here we go. Yep, you bet. You might want to sit forward for this, Dr. Gauhar. All right, here we go.
I don't think I can beat Chrissy.
Well, that's okay. That's okay. But let's see what you got. Let's let her take you through a little workout. I understand that valves are removable. Worries me that if they are removed, that some damage may happen. I'm scheduled for mid-August, and this does concern me as I'm not on O2 now and worry that it could make me need O2.
So like we said, transiently, if you need oxygen, that can happen. But generally, if the valves need to be removed, it's a very simple, straightforward procedure. And it does not cause any damage or significant damage to bronchial tubes. Even if your bronchial tubes get a little abrasion, they heal very well. So removing the valves is really not that big a problem.
All right, Dr. Gauhar jumps out to a commanding lead. Chrissy, get ready. How does a peripheral condition such as AFib affect you being able to have the valve treatment? And I'll say the same with a pacemaker.
Well, the big thing is being able to go to rehab because obviously working out and exerting yourself is going to increase your heart rate anyway. So if you're having an arrhythmia or irregular heart rates like AFib, obviously that will be something that we would want to work with your cardiologist and also your pulmonologist just to be sure that you're safe enough to be able to handle rehab. And as far as a pacemaker, no, that won't affect it.
And your blood thinner will need to be stopped for about 2 days before the procedure if you're on blood thinner for AFib.
So your blood thinner has to be stopped. How long did you say? I'm sorry.
Well, depending on what particular blood thinner you're on, but generally anywhere from 2 to 5 days.
Okay, I didn't hear you. I'm sorry. I wasn't expecting that kind of sneak attack after Chrissy evened things up. When you are attempting to place a valve and you find out that the patient does have collateral ventilation and they cannot get the valve, are there any alternatives other than standard of care?
So we check multiple lobes. If the patient has multiple lobes that can be potentially treated based on that Chartis report. So we pick our primary target, meaning our first choice, and we often have a second choice. So if the first choice doesn't work out, we'll try the second choice. If the collateral ventilation is positive, meaning valves are not going to work, at that point, we are not going to do anything. At that point, your procedure is over, and then we'll talk to you afterwards, usually in clinic, about what's the next step. It could be referral for transplant, could be change in your treatment, could be other potential research trials that are always out there. But no, your procedure is over if you are collateral ventilation positive.
But at that point, we can also recommend the lung volume reduction surgery, possibly. And as he mentioned, we have plenty of clinical trials, and we're even waiting on Pulmonx and some of our European counterparts to come up with some sort of research for these folks to help with collateral ventilation. So we hope to see that on the horizon.
Gotcha. All right. What about previous lung volume reduction surgery 5 or more years ago? Have you ever placed a valve in those individuals?
I have not. I don't think we have had any patients who've had this kind of surgery. Now, lung volume reduction surgery is not really that often performed, and it's not performed very widely. So we haven't had any patients. obviously the
It would
more,
depend on the lobe,
yeah, it depends
the
on the load.
target.
That by itself does not rule you out. Having said that, if you've had surgery in your lung, then the anatomy and is not normal, which can sometimes make it difficult for us to place a valve or for your lung to respond as expected, because there's going to be scar tissue in your chest. So the more variables we introduce, the more unexpected or uncertain the response can become, but it does not rule out us evaluating you and considering valve placement.
Is advanced age a disqualifier, and what is the oldest, or I should say most mature patient you've done?
86.
I don't know how you measure maturity. I mean, my wife tells me that I'm pretty immature sometimes. So I can't answer about maturity, but obviously it's meant for adults. Usually by the time you develop COPD, and by the time you develop COPD or emphysema, I should say, that's severe enough to bring you to our clinic, or in our view, most patients are already in their 50s, 60s, sometimes even 70s. But age by itself is not really a reason for us to deny this intervention. It depends on how
Overall health.
overall health. And we've had 80 years old who are more functional and healthier and more motivated than some 40 years old. So, I'm not going to take that number as something against them.
But
Gotcha.
our oldest patient was 86.
Yeah.
And he's doing great. And he was
All right,
otherwise.
break it up, you two. Break it up. Back to your corners. 86, that's awesome.
This is Kentucky. It's the Derby.
What's that? Yeah.
It's Kentucky, the home of the Derby.
That's right. That's right. You guys should make special hats, like for your valve patients afterwards. That would be awesome. I can work on that with you. How many have you done, Dr. Gauhar? How many? That's a personal question. People want to know how many have you done.
I don't remember the exact number, but I think we've done close to 40. Is that can I help me out?
Yes. This can be a team. This could be like in wrestling when they were foes and now they're friends. So go ahead.
All right. So
we'll end together.
So 39 have gone to table, 4 had collateral ventilation, 1 we were inconclusive and going to bring back to the table, and the others were CV negative and received valves.
Well, there you go. That's why I have Chrissy.
Yes.
And our pneumothorax rate is about 10%, where in the study it was 25 to 26%. So we've had a low pneumothorax rate.
That's awesome. Will valves improve CO2 levels?
Good question. I mean, I guess that's something that's a little bit uncertain and variable. Overall, they tend to improve your gas exchange, and by allowing your diaphragm to function better, they can potentially improve your CO2, but that's not something that will always be the case. In fact, if your initial CO2 level is very high, and I think on one of the slides we did mention, if it's very high, above 55 or so, then we generally don't even consider valves, because the risk of having complications goes up.
Gotcha.
Yeah.
If this won't help your oxygen usage or less medication, but you said that it might help your oxygen, why would you get the valve? So if I could just reiterate what you just said. So basically, it could improve your oxygen, and it's going to improve your potential lung function and mechanics and improve your quality of life. Yes?
Yes.
Okay.
Right.
Where is your clinic located? We'll give you a little free plug here.
Okay.
University of Louisville, downtown Louisville at Preston and Jackson Street.
Okay. Okay. I have a large hernia on my diaphragm. Is this a problem?
It can be. It depends.
Has to be evaluated.
Yeah, it needs to be evaluated. If it's really large enough to be affecting your diaphragmatic function or your lung function, then, again, that's something that the valves cannot fix.
And if you get the hernia repaired, are you then a candidate?
Yes, you can be.
Okay, I'm going to ask one selfish question. I'm not going to ask for some free valves, don't worry. But how has COVID affected you guys? And what do you see as kind of like what was, what is, and what do you see the future being for your program?
Well, obviously, when we started lockdown back in March, then we were not doing valve procedures. All the elective procedures, whether it was valve or other major surgery, was not being done. Our clinics were more or less closed. A lot of our patients could not travel at all. So we were not doing valves for several weeks, if not a few months. We have started back up. We are obviously being a little bit more careful in terms of who we bring to clinic. We don't want patients to put their health at undue risk. I think the biggest change that I've noticed is that now patients have to be tested for COVID and has to be done within a certain time window before the procedure. So it adds an extra step to our procedure, which is a logistic problem at worst. I don't think it really prevents us from going forward, but it just adds a step. So I think eventually we will learn how to live with COVID and how to work through this problem. And I think we already are almost back to where we were before COVID.
Chrissy, anything to add to that?
Well, I was going to say a lot of patients obviously are having a lot of anxiety with COVID, but once they actually get back into rehab and see the measures that they put in place to keep them safe, their visits here for doctor's appointments or testing, once they're here, they seem to be a little more at ease because they see, what we have in place to keep them safe and to keep us safe and obviously other patients. As far as COVID goes, a lot of people are kind of waiting and expecting that it's going to, not that it'll lift completely, but that it's going to make life a little easier for folks. So our referral base is really, since COVID, we continue to get referrals every single day. So patients are still willing and want to get in here and get this procedure done.